this is incredible to have 350 people in Albany coming to a vascular education meeting. We could not do this without the nurses who work for us and the nurse clinicians, the nurse practitioners who help us see patients, the LPNs, the lab techs, the OR techs, the angio techs, the vascular ICU, who's done a superb job of being the first ICU to give comprehensive care and help us set up the system. So I just want to thank all of you for coming and all of you for participating in our education and making this system work as well as it does. And lastly, I want to introduce, at least my last introduction, for Dr. Byrne, who's going to give us our next talk. John Byrne has come to us. He was born in England, and he's been trying to deny that fact for the last 30 years. It says born in England, nationality Irish on his CV. He trained in Galway, and he trained in Limerick, and I was trying to come up with a great Limerick, but most of the ones I will have to tell you at the bar later. He is an incredibly educated, knowledgeable, and well-spoken and well-written gentleman. Whenever we have any difficult, complicated book chapters or papers to write, we usually take a swipe at him first, and then I call up John, and I go, John, can you write this chapter? And he goes, sure, when's it due? And I go, last week. Can you ever give me one that's on time? And I go, not if I can help it. But John has done a tremendous job for our system. He's worked up in Glens Falls and run our system since 1993. He's a superb technician, a great physician, a wonderful human being, a good father, and a great author. So I want to introduce John Byrne for the next talk. John.
I'm going to get asked by Manny and Sharon to give this talk this evening. I kind of wondered why they were asking somebody from Ireland, I am from Ireland, who works in Glens Falls and sometimes in Saratoga, to give a talk in Albany on limb-threatening emergencies. And then I realized tomorrow's the 3rd annual Vascular Golf Day, and, and who better than somebody from the island of Ireland to give a talk about golf, where we actually... So here in clockwise order, you can see Pádraig Harrington, Rory McIlroy, Graham McDowell, and the People's Champion, Darren Clarke. You can see celebrating the British Open win last Sunday in true style. Bottle of water totally intact, pint of Guinness not so intact. So now I know I got the invitation. So I'm here tonight to talk about limb-threatening emergencies. Now, Dr. McKenna talked a little bit about vascular trauma. I'm not going to talk about vascular trauma. I'm going to talk about what most of us encounter most days of the week as representing a limb-threatening emergency, and that's acute limb ischemia. And acute limb ischemia is defined as any sudden decrease in limb perfusion causing a potential threat to limb viability. And what this basically means is some catastrophic event has occurred to imperil that limb, and unless that process is reversed expeditiously, the patient's going to lose that leg. Now, unlike a lot of other conditions that we encounter, there really isn't any role for blood tests or x-rays or even, with due respect to Dr. McKenna, ultrasound in the diagnosis of this condition. The diagnosis of this condition is primarily clinical. Ultrasound, angiography, blood tests will have a role in treating the condition, but diagnosis is clinical. So what do I mean by that? So what are those clinical features that allow us to make the diagnosis? Well, in a previous life, I used to teach medical students, and I used to have to explain to them the 6 features of acute ischemia, the 6 Ps. I also had to explain to some of them who are now professors of medicine that that wasn't the common garden vegetable that we're all familiar with, but rather it was the letter P. And there's 6 Ps representing 3 symptoms and 3 signs that you diagnose acute limb ischemia with. The first P is for pain. Patients with acute limb ischemia, be it arm or leg, will present with severe, unremitting pain that needs narcotic analgesia, usually morphine, to alleviate. And patients who have been through acute limb ischemia and come out the other side, I've usually said it's the most intense pain they've ever experienced. The second P is paresthesia, which means pins and needles. As we came up among the other talks, neurological tissue is exquisitely sensitive to hypoxia. And the most sensitive nerve fibers in the extremities to ischemia are those small fibers which conduct light sensation and proprioception. So patients, when these nerves become ischemic, present with pins and needles of paresthesia. The third P is paralysis, which is a total misnomer. These patients aren't paralyzed. What happens is they're developing muscle infarction. And when we as vascular surgeons go and see patients with acute ischemia, we'll often ask them to wiggle their toes, which may seem like a silly thing to ask, but what we're really trying to assess is whether the intrinsic muscles of the foot, which are most susceptible to ischemia, are actually still functioning. Has the patient got enough ATP, enough oxygen in those muscles to actually contract them? If they haven't, it means the acute ischemia is far more profound than at the more lesser forms of presentation. Patients like the one we saw on the last slide will often present with pallor, profound pallor of the foot, or occasionally the hand, and occasionally have a waxy white appearance to the foot, and it'll almost look cadaveric. The absolute prerequisite for diagnosing acute ischemia is lack of pulses. If you don't have pulses, you probably have acute ischemia. If you do have pulses, well, then there's another cause for your pain or pins and needles. And finally, it's a bit of a stretch, but perishing with the cold is the other, is the last sign of acute limb ischemia. So what causes acute limb ischemia? Well, from the outset, it's worthwhile saying that acute leg ischemia is far more common than acute arm ischemia. Acute arm ischemia occurs, but it's far less frequent and is, to an extent, far less dangerous than acute leg ischemia. On occasion, you can treat acute arm ischemia with blood-thinning drugs or like heparin or Coumadin. You can almost never do that with acute leg ischemia. So the common cause of acute leg ischemia are embolism. And an embolus, for those of you who don't know, is an undissolved material which has traveled in the bloodstream and impacted an artery to cut off the blood supply to the tissue that artery supplies. And it usually impacts an arterial bifurcation and usually originates from the heart, or in the case of the leg, from an aortic aneurysm. And this is an acute limb-threatening emergency. The second set of events that might cause acute ischemia is in situ thrombosis. Now, what's in situ thrombosis? In situ thrombosis means that these patients have underlying atheroma of peripheral arterial disease in their arteries. And that's progressed to the stage where the flow through that artery becomes so sluggish that the artery actually thromboses and causes acute ischemia. There are other causes such as the popliteal artery aneurysm and other fairly esoteric causes of acute leg ischemia, which I won't go into. Acute arm ischemia is far more straightforward. It's mostly embolic disease that causes acute arm ischemia. So let's talk a little bit about acute leg ischemia. When we're talking about treating acute leg ischemia, we're talking about the amputation prevention business. We're talking about stopping the guy on the left becoming the guy on the right. So we're into the amputation prevention business. So how long do we have? Patients and relatives, when they present to ER with a patient with an acute ischemic limb, will say, how long do we have? What's the hurry? And there's two approaches to assessing how much time you have to treat an ischemic limb. One is a systematic approach, which has had a lot of input from very venerable vascular surgeons and is also widely not used and widely ignored. And there's a pragmatic approach. The systematic approach is a system that was developed in 1997 by Rutherford and others, where you can assess acute limb ischemia on the basis of the leg being viable, which is class 1, to class 3, which means the limb's irreversibly ischemic and has to undergo amputation. Now, pictures are often better than words, and this is a patient who has a category 1 type ischemia, where you have time on your side. This is a patient who arrived in our office one afternoon in Glens Falls Hospital with acute pain in his left foot, pins and needles in his left foot, and also pallor on elevation. When I got him to drop his feet down, the left foot became intensely rubrous. You can see from the arrow the patient had previously had a fem anterior tibial bypass in the right leg. And this is a patient in whom we had time on our side. We could admit, heparinize, obtain an angiogram, and then he did very well from a fem dorsalis pedis bypass in the left foot. So this is category 1, whereas you've got time on your side and you've got time to get angiography. Category 2 is slightly more severe. This is a patient with a very cyanosed foot who came into not Glens Falls, but another hospital I worked in. The skin still blanches, which means the leg's still viable, but the usual capillary refill time, as I used to tell medical students, is the time it takes to say capillary refill. In other words, 2 or 3 seconds. This patient clearly didn't had a prolonged capillary refill, because I could push my finger on his foot, take my camera, and it was still blanched by the time I went to take the photograph. So in this type of patients, if they arrive in the middle of the night, you may very well take them to the OR, and I frequently do, without calling in the IR text and doing a diagnostic angiogram. There are a group of patients in whom revascularization is not possible and cannot be done and should not be done. This is a 72-year-old lady who was admitted to Glens Falls Hospital from a nursing home. She had Alzheimer's. She had profound ischemia of her right leg. And this was 72 hours, he reckoned, following the initial event. She had other diseases which made her a terminal patient. In this patient, treatment was palliative. She had such other comorbidities that really comfort care was the only thing. And there are another group of patients whom we see presenting, or we're asked to see in consultation, for whom acute ischemia is their terminal event. It's the final event they're going to encounter. And for those, it's totally correct and totally the right thing to do to treat them conservatively. Not everybody who presents an ischemic limb should be revascularized. So I said that's a systematic approach, and it's very good and very well thought out. But what actually happens in reality? Well, what actually happens in reality is a slightly more pragmatic approach. Surgeons are pragmatists. Vascular surgeons are probably more pragmatic than most. And the approach we often use, and if any of you get phone calls from us, or you call us in the middle of the night with an ischemic limb or a patient you think is ischemic, the questions we'll often ask you is, well, has the patient got normal sensation, and has the patient got normal motor function? And the reason we ask you that is because if they have normal sensation and normal motor function, we know we've got time on our side. We can heparinize that patient, do angiography, and then do a planned reconstruction. But if you call us in the middle of the night and you say the patient has absent sensation, the whole foot's numb, they cannot wiggle their toes or wiggle their fingers, toes in this case, well, then they get immediate surgery. You may not even stop at the IR suite to do an angiogram. So what's the cause of acute leg ischemia? Well, in 2011 in the United States, as in the United Kingdom, the commonest cause of acute leg ischemia is arterial thrombosis. This is the results of a survey from the United Kingdom Joint Vascular Research Group on acute ischemia. This is a couple of years old now, but it holds very much true today. Emboli only account for about 38%, 40%. But this wasn't always the case. If you look at the Scandinavian data from the 1980s, in Sweden, Norway, Finland, Denmark, the Scandinavian countries, or Nordic countries, should I say, have very good vascular databases on all aspects of vascular disease and vascular treatment. And when you look at their population data from the mid-1980s, you can see that it wasn't always this way. The emboli were far more common cause of acute leg ischemia in the mid-80s than acute thrombosis. So what caused this change? What brought this change about? Well, one thing was a great appreciation of atrial fibrillation and need for anticoagulation. That was one reason. With Dr. Pan here, there was a greater treatment of valvular heart disease. And the third reason was probably an invention of penicillin. Penicillin was discovered in 1928 and then mass-produced in the 1940s. Around that time, streptococcal infections were really not well treated. So with the advent of penicillin, it was possible to treat streptococcal infections. Streptococcal infections, when they're not treated, give rise to rheumatic fever. And rheumatic fever is an intense inflammatory reaction, if you like, which causes damage to skin, joints, and heart valves. So a lot of these patients in the 1930s and 40s who were inadequately treated for streptococcal infections developed rheumatic heart lesions. And these are disappearing as that population ages and gets older, and also as Dr. Pan and his colleagues have treated those lesions more aggressively. So how do you treat acute leg ischemia? Well, it's really quite simple if you think about it. Emboli equals embolectomy, and the Fogarty catheter still works very well. For in situ thrombosis, you either do a surgical bypass or catheter-directed thrombolysis. Now, femoral embolectomy. Femoral embolectomy is usually a straightforward procedure for acute arterial embolus, performed either under local or general anesthesia. You can do a popliteal plus or minus, femoral plus or minus popliteal exposure. It's a relatively simple procedure to perform. The Fogarty catheter, which is invented in 1963, is pretty much unchanged since that time and is just as effective now as it was then. So when you perform the procedure, if you turn your attention to the right of the screen as you look at it, you can see the lower right picture shows a Fogarty catheter being placed proximally, retrieving a clot proximally to establish inflow. You then pass your Fogarty catheter distally and retrieve whatever clot you can. If you're very lucky, you'll get a clot like a photograph there at the top. Now, at the end of it, a completion angiogram is the ideal thing to do. Where I work in the peripheries in the North Country, it's not always possible to do a completion angiogram in the middle of the night, but I know and hope that's going to change in the next year or two. For in situ thrombosis or thrombosed graft, thrombolysis or bypass is the way to go. Catheter-directed thrombolysis seems intuitively to be a very good thing to do. It was first established by Dave Berridge in 1991 from Leeds. And basically what the idea behind catheter-directed thrombolysis is to place a catheter in the occluded artery or in the occluded graft and then spray lytic agent, usually TPA, into that graft or into that artery to dissolve the clot and restore reperfusion. If there's a stenosis in that clot or in that graft, then you can treat it with angioplasty at the same time. And in theory, it's a great thing to do. The secondary benefit that's, by proponents is that you thereby can often convert a major procedure into a more minor procedure. There is a catch. On the right of the screen, you see a patient who came into our office, very busy office in Glens Falls. I had performed a FEM AK pop gore bypass several years previously for claudication. And after several years of determined smoking, she represented with an occluded bypass graft. And this is a patient who presented what we were calling category 1 ischemia. We knew we had time on our side. So we brought her to the angiography suite and did an angiogram. The top picture shows an occluded femoral popliteal bypass graft. We managed to lace the graft with a lysis catheter, and that's the complete results at the bottom right. We also note that it took at least 36 hours for us to do this. So you have to have 36, 48 hours to play with and know the patient's going to survive, or the limb's going to survive for that length of time before doing thrombolysis, and that's the catch. You need to have time on your side, and frequently for the patients we see, we don't seem to have the luxury of that time. So are there good candidates for catheter-directed thrombolysis? There are. Acute thrombosis of grafts, where you have time, is good. Popliteal artery aneurysm is probably a good one. Bad candidates are emboli, patients with emboli, where you have a big wodge of insoluble clot which has been sitting in the heart for several weeks, several months, several years, and is now lodged in the femoral artery. That's not going to be a good candidate for catheter-directed thrombolysis. If a patient has acute postoperative ischemia, attractive as it may seem, lysis is not the thing to do. There's obviously a technical reason why that graft failed, and also you can't perform lysis because of bleeding concerns for at least 6 weeks after surgery. And like I say, you have to have time on your side. Bypass for acutely ischemic limbs is effective. We do a lot of it. In fact, it's probably the commonest treatment myself and Dr. Dadian certainly do in Glens Falls. It treats the underlying problem. Patency bypass rates are similar to elective bypass, so you get a good outcome from emergency bypass for in situ thrombosis. So when we get patients out the other side and we get them with a nice warm foot or a nice warm arm, or a nice warm hand, foot should I say, we're talking about legs, patients often say, well, what can I do to prevent this happening again? Well, there are good data from Abbott in the United States and from the SwedeVasc database, and also from Bruce Campbell and the Joint Vascular Research Group in the UK, that systemic warfarinization or heparinization following an acutely ischemic event can not only reduce the risk of recurrence, but also can improve long-term survival. So it's our policy to warfarinize these patients or anticoagulate them post-operatively. So I've spoken about leg ischemia, a little bit briefly about acute arm ischemia. It's less common. About a fifth of cases are due to acute ischemia. It's less dangerous, and I'll talk about that in a second. It's usually embolic, and embolectomy is extremely effective treatment for this. The causes of acute arm ischemia, like I said, are by and large emboli. Trauma can account for a small number, and in situ thrombosis is a rare cause of acute arm ischemia. If you look at the right side of the screen, it shows where all the emboli come from. It's usually the left atrial appendage, or from a mural thrombus following an MI, or from a left ventricular aneurysm. When we treat acute arm ischemia, at least when I treat, I usually don't obtain an angiogram. I usually find they're unnecessary, and that's the consensus really in the literature. It's not something that I'm being renegade about. If you can feel a palpable subclavian pulse or a palpable axillary pulse, you usually do not need an angiogram. If you can't feel a subclavian pulse or an axillary angiogram, which is a rare event, then those patients need an angiogram. An embolectomy is very effective and very well tolerated. And the final point I make about acute arm ischemia is really is very little role for conservative treatment. Historically, it was said that if patients are very unwell, well, you can treat them with heparin and long-term warfarinization. When you follow those patients up, 75 to 80% of them will have debilitating arm claudication. So the time to act and the time to prevent that is not when they present 6 months later with a chronically occluded radial or ulnar artery, but when they present with acutely ischemic arm. And like I said, embolectomy is a very simple thing to do. You can do it under local anesthetic if need be. Now, when I was giving this talk, when I started out, I said that we made the diagnosis of acute limb, acute arm or leg ischemia on the basis of clinical signs. It's not a blood work diagnosis, it's not an X-ray diagnosis. 3 of those were symptoms, 3 of those were signs. Now, there are a group of patients who really can't give a history, and they're the patients who are really at the extremes of life. On the left of the screen, you see our patient earlier on who's had Alzheimer's, and really couldn't tell the attendants at the nursing home that she had pain, paralysis, paresthesia. And the patient on the right of the screen, in one of my previous jobs, I worked as a vascular surgeon in a university teaching hospital. One of the heart sync pages you used to get was to the neonatal intensive care unit. vascular surgery and neonatal intensive care don't go well together. This is a 28-week patient of mine, born at 28 weeks. A lot of these patients require umbilical artery catheterization, and one of the complications of umbilical artery catheterization is aortic thrombosis. And this is a patient we were asked to see. We treat him anticoagulation. Diagnosis is actually made on ultrasound, Dr. McKenna. So that's, but like I say, these are the extremes of life, and these are two groups of patients who really can't give you a history of acute ischemia. Now, in conclusion, acute limb ischemia is a vascular emergency. It does mandate urgent intervention. Emboli, surprise, surprise, are best treated by embolectomy, and thrombolysis has a niche role in acute arterial thrombosis. But surgical revascularization, certainly where myself and Dr. Dadian work, is the mainstay. And limb salvage rates are very high, especially in expert hands. But if I ever develop acute limb ischemia and I'm brought into Glen Salls Hospital, and all the staff from Glen Salls Hospital are over there on the left, can't save my leg, and I end up having a prosthesis, this is the prosthesis I want. Thank you.